Hello and welcome. Today we're diving into a complex and often overlooked condition, ureteral endometriosis. This occurs when endometrial tissue, the tissue that normally lines the uterus, grows outside of it and invades the ureter, the tube that carries urine from the kidney to the bladder. It's a challenging condition that can significantly impact a woman's health and quality of life. Let's explore what it is, why it happens, and how it's managed. The exact cause of endometriosis, including ureteral endometriosis, remains a topic of ongoing research. Several theories exist. One prominent theory is retrograde menstruation, where menstrual blood containing endometrial cells flows backward through the fallopian tubes and into the pelvic cavity. These cells can then implant and grow in ectopic locations, including the ureter. Another theory involves the transformation of cells outside the uterus into endometrial-like cells. Genetic predisposition and immune system dysfunction may also play a role, making some women more susceptible to developing endometriosis than others. Ureteral endometriosis is relatively rare, and its specific causes within the broader context of endometriosis are still being investigated. When endometrial tissue implants on or within the ureter, it triggers a cascade of events. The endometrial tissue responds to hormonal fluctuations just like the tissue inside the uterus. During menstruation, this ectopic tissue can bleed, causing inflammation and scarring around the ureter. This inflammation and scarring can lead to narrowing or obstruction of the ureter, known as ureteral stricture. The stricture then interferes with the normal flow of urine from the kidney, causing a backup. This backup can lead to hydronephrosis, which is swelling of the kidney due to urine accumulation. Prolonged hydronephrosis can damage the kidney and potentially lead to kidney failure if left untreated. Ureteral endometriosis is a relatively rare manifestation of endometriosis in general, occurring in approximately 1–2% of women with endometriosis. Because endometriosis itself is difficult to diagnose, its true prevalence may be underestimated. Ureteral involvement is more common in women of reproductive age, typically between 20 and 40 years old. However, it can occur in women of any age who have endometriosis. There is no known racial or ethnic predisposition, but research continues to refine our understanding of the condition's epidemiology. The signs and symptoms of ureteral endometriosis can be subtle and often overlap with other conditions, making diagnosis challenging. Some women may experience flank pain, which is pain in the side or back related to kidney involvement. Other symptoms may include urinary frequency, urgency, or dysuria, which is painful urination. Hematuria, or blood in the urine, can also occur, but it's not always present. In some cases, ureteral endometriosis may be asymptomatic, only being discovered incidentally during imaging for other conditions. Because ureteral involvement can cause hydronephrosis, some patients may only experience symptoms related to kidney dysfunction. Diagnosing ureteral endometriosis requires a thorough evaluation and often involves a combination of imaging and surgical procedures. Initial evaluation may include a physical exam and review of medical history. Imaging studies such as ultrasound, CT scan, or MRI can help visualize the ureter and detect any signs of obstruction or hydronephrosis. An intravenous pyelogram, or IVP, is an X-ray that uses contrast dye to vise the urinary tract and can help identify ureteral strictures. Cystoscopy, a procedure where a thin tube with a camera is inserted into the bladder, can also be used to examine the lower urinary tract. The gold standard for diagnosis, however, is often laparoscopy, a minimally invasive surgical procedure where a small incision is made and a camera is used to directly visualize the pelvic organs. Biopsy of the affected tissue during laparoscopy can confirm the diagnosis of endometriosis. Ureteral endometriosis can be classified based on the location and severity of the endometrial implants. Intrinsic ureteral endometriosis refers to endometrial tissue that has grown into the wall of the ureter, whereas extrinsic ureteral endometriosis involves endometrial tissue that is located outside the ureter but is causing compression or obstruction. The degree of ureteral obstruction and the presence of hydronephrosis also contribute to classification, ranging from mild to severe. These classifications help guide treatment decisions and predict prognosis. The primary goals of treatment and management of ureteral endometriosis are to relieve symptoms, preserve kidney function, and prevent recurrence. Treatment options vary depending on the severity of the condition and the patient's individual circumstances. Medical management may involve hormonal therapy, such as oral contraceptives, progestins, or GnRH agonists, to suppress the growth of endometrial tissue. However, medical therapy alone is often not sufficient for ureteral endometriosis, and surgical intervention is frequently required. Surgical options include ureterolysis, where the endometrial tissue is removed from around the ureter, or ureteral resection and reimplantation, where the affected segment of the ureter is removed and the remaining ends are reconnected. Minimally invasive techniques, such as laparoscopy and robotic surgery, are often preferred to reduce recovery time and complications. Regular follow-up is essential to monitor for recurrence. Currently, there are no definitive preventive measures for endometriosis, including ureteral endometriosis. However, certain lifestyle modifications and medical interventions may help reduce the risk or slow the progression of the disease. Maintaining a healthy weight, engaging in regular exercise, and avoiding exposure to environmental toxins may be beneficial. Some studies suggest that the use of oral contraceptives may reduce the risk of endometriosis, but more research is needed. Early diagnosis and treatment of endometriosis in general can help prevent complications such as ureteral involvement. The prognosis for women with ureteral endometriosis depends on the severity of the condition, the extent of kidney damage, and the effectiveness of treatment. Early diagnosis and prompt treatment can help preserve kidney function and prevent long-term complications. Surgical intervention is often successful in relieving ureteral obstruction and improving symptoms. However, recurrence is possible, especially if the underlying endometriosis is not adequately treated. Recent research focuses on developing more effective medical therapies and improving surgical techniques to minimize recurrence and preserve fertility. Furthermore, research in the genetic and immunological factors contributing to endometriosis is ongoing, with the hope of identifying new targets for prevention and treatment.